the series, Tribal and Indian Healthcare Systems. We have a panel of 3 people on this series. We're going to wait a few minutes just to get people that are still signing in and entering the waiting room. So we're just going to wait a few minutes. And I just wanted to thank you to the attendees for the commitment of their time today. Our panelists are Dr. Pamela Endofhorn, Dr. Glenna Stumbling Bear Riddle, and Dr. Anita Warrior. Again, we're just going to wait a few minutes for other attendees to get signed on and admitted to the room. Again, this is the 4th webinar in a series of 6. It doesn't matter if you did not attend the other 3. They are going to be out on our YouTube channel. We're just getting those prepped and ready to be put out there. So just keep on checking our YouTube channel and they will be out there soon. Okay, do you want to go to the next slide? So just a little few housekeeping things that we need to take care of. You know, it's important to recognize how we got our funding and all that. SPRC is the only national resource center for suicide prevention, and we are housed at the Oklahoma Health Science Center, and it is supported through a grant by the U.S. Department of Health under this under SAMHSA, the Substance Abuse Mental Health Service Administration, and it is a 5-year grant right now. And it's just really important to acknowledge that. And again, it is the only federally funded resource center devoted to advancing the implementation of the National Strategy for Suicide Prevention. I want to take this time to introduce Dolores Sabia Bigfoot. She is one of my mentors and she's the senior advisor at SPRC. And I just want to take this time to acknowledge her and thank her for being here to give us our land acknowledgement. Dee?
Thank you. We always wish to bring land acknowledgement into our conversations, and that it is, let me read the land acknowledgement and then I'll explain it a little bit more. We acknowledge that the land that now makes up the United States of America was a traditional home, hunting ground, trade exchange point, and migration route for more than 574 American Indian, Alaska Native federally recognized tribes, and many more tribal nations that are not federally recognized or no longer exist. We recognize the cruel legacy of slavery and colonization in our nation and acknowledge the people whose labor was exploited for generations to help establish the economy of the United States. We honor Indigenous, enslaved, and immigrant people's resilience, labor, and stewardship of the land, and commit to creating a future founded on respect, justice, and inclusion for all people as we work to heal the deepest generational wounds. And what we want to recognize is that the more formal land acknowledgement comes from Aboriginal people, but our traditional, our Australian Aboriginal people, but our cultural teachings within many of our tribes have different land acknowledgements when they have established their camps and established their place of refuge. And so what we want to be reminded of is that land acknowledgement is about finding a place or a safe space that was about safety and protection, about inclusion, of those that were in the circle and those that were visitors, and that is about a circle of protection, safety, in order to include all. So to build on our cultural teachings of being respectful, to recognize fairness and inclusion. Thank you.
Thank you, Dr. Bigfoot. I appreciate that and taking the time to join us. I just feel so honored to be in this virtual room with all these powerful women that all have higher education, and just to share their knowledge and good information that they're going to share. This is a big topic, and we could spend all day, maybe even a couple of days on this topic. And there's probably so many questions that everybody has and so much information that we could share. We just picked up a couple of questions that we're going to share and ask each of the panelists today. And towards the end, we're going to have maybe a group discussion within the panelists. But right now, I want to take a few minutes and have Dr. Pamela Endofhorn introduce herself. Pamela? Dr.
Hi. Hi, good morning. I am Dr. Pamela Endofhorn. I am the National Suicide Prevention Consultant for Indian Health Service. I am from the Pine Ridge Indian Reservation, born and raised in Pine Ridge. That makes me Oglala Lakota. I currently coming to you from Longmont, Colorado, the unceded land of the Ute, Cheyenne, and Arapaho. And my background, by profession, I am a licensed clinical social worker. I have a doctorate in social work from the University of Pennsylvania, and I have advanced practice licenses in the state of North Dakota and Minnesota. And I'll turn it back to Vicki.
Thank you, Pamela, Dr. Endofhorn. I appreciate that. I should probably let you all know that I am Blackfeet from the Blackfeet Reservation, and I have worked in suicide prevention for almost 20 years. I am not clinical. I come from the prevention side of things, and I'm your facilitator, and I like to bring things together and be your resource for things. And now I would like to take the time to have Dr. Glenna Stumbling Bear introduce herself. Glenna?
Hatso Goihani, Glenna Stumbling Bear Riddle, Day on Day. It's wonderful to be here with you all. I am a Kiowa citizen. I reside in Oklahoma, in Indian Territory, and I work as a psychologist. I've been licensed since 2011, have my own private practice, which is called Resilient Tribal Roots. And I graduated with my PhD from Oklahoma State University, and I have not yet made it out of Oklahoma, but maybe one day, we'll see what happens. And again, thank you for inviting me to be on this panel with all these wonderful women, and I'm excited to share with you all. Thanks again, Aho.
Thank you, Dr. Stumbling Bear Riddle. And now I would like to have Dr. Anita Warrior introduce herself and to, again, just be part of this amazing panel. Dr. Anita Warrior.
Thank you, Vicki. So good afternoon or good morning, everyone, depending on where you are. It's such a pleasure to be here, and I thank you for your willingness to spend time with us and allow us to share from our experiences. So again, my name is Anitra Warrior. I'm from the Ponca tribe of Oklahoma. I grew up in Oklahoma and then moved to Nebraska and went to school here. So if any of you are familiar with college football from back in the day, that's like a major rivalry. So that was a lot of fun between my family in Oklahoma and my in-laws here in Nebraska. So today I am at one of our clinics in Walt Hill, Nebraska, which is on the Omaha Reservation. We have 3 reservations in Nebraska, and we've been blessed to have multiple clinical sites through Morningstar, which is a private practice serving reservations, as well as doing integrated care. And so we've been providing these services since 2012, and we started in collaboration with the Winnebago Public School on their reservation. And then through the graciousness of the Santee Sioux Nation, we've been able to have significant partnerships, and now we're able to provide statewide services to anyone who self-identifies as Native. And the other piece that I think is really nice about our clinics and what we've been able to provide is that we've been providing telehealth services since about 2014. So we've been very skilled in that and had started doing that well before the pandemic. And so that's been really helpful when we talk about services that are provided to our rural locations. So again, thank you so much for being here with us. And it's an honor to be on this panel. Thank you.
I appreciate all three of you so much and agreeing to be a part of this panel. And I want to take a minute to acknowledge the amazing Angie Mize and the amazing Colleen Solitis. They are behind the scenes. They both work for SPRC as project coordinators, and they make things work for us, like I said, behind the scenes, doing tech things. And I'm going to ask the three panelists different questions, and we will have time at the end for questions and answers. And if you have questions, you can put them in the chat, and Angie and Colleen will field those for us as we go along. But again, I just want to take the time to acknowledge those two, because these webinars take a little bit of time to put together, and they wrangle me and make sure that I get things going and get things done on time. And these wouldn't happen without these two. So I just want to acknowledge them and say I appreciate them, and just things wouldn't get done without these two. So I appreciate them. And again, I appreciate the panelists. Aishka. So I'm gonna field the first set of questions to Dr. Endahorn. And so my first question is, what is the Indian Health Service?
The Indian Health Service, we are a federal agency under the U.S. Department of Health and Human Services, and we provide health care to 2.5 million American Indian and Alaska Natives. Our mission as the primary healthcare agent under the U.S. government upholding the trust and treaty obligations of Native people, our mission is to raise the physical, mental, social, and spiritual health of American Indian and Alaska Natives to the highest level. In a lot of discussions that I do, I often say American Indian, Alaska Native. I also switch back and forth between Native people. So I just want to make sure people are aware of that. I also tend to have to say Indian, because when we talk about eligibility and legalities, when it comes to Indian Health Service, we often use the word Indian. So I know it's not colloquial anymore, and it can be kind of uncomfortable. So I really wanted to acknowledge that. But Indian Health Service overall, we provide services across the U.S., predominantly in 37 states, and of course, Alaska. We provide health services through 12 area offices and 170 IHS and tribally managed services. We employ over 15,000 staff, from physicians to dentists to optometrists. We also provide funding for urban Indian health organizations. And we also provide a lot of information on environmental impact. So we have a facility portion that looks at, example would be radon and health and water and all of that. Currently, we have 24 hospitals, and we have 51 health stations, 51 health centers, 24 health stations, 12 school health centers, which I don't think a lot of people know that we do that, but we actually do have embedded services within schools, as well as 6 youth travel treatment centers. So our system is quite robust. We provide everything from primary care to pharmacy, dental, optometry, even medical surge and specialized such as podiatry. And we also have critical access hospitals, 5 of which are direct service. And then we also provide a lot of scholarship and loan repayment to Native people who've gone on and become a healthcare agent. And if they want to do repayment, they can do repayment with us.
Thank you so much for that. Indian Health Service, IHS stands for Indian Health Service, correct?
Correct.
Thank you for that. What are the 12 IHS areas?
So the IHS areas, there's 12 of them. There's of course headquarters, which is located in Rockville, Maryland. And then there's the Alaska, Albuquerque, Bemidji, Billings, California, Great Plains, Nashville, Navajo, Oklahoma City, Phoenix, Portland, and Tucson.
Thank you for that. Are there eligibility requirements? And if there are, what are they?
Oh, yes, there are eligibility requirements. You have to be of American Indian or Alaska Native descent as evidenced by a couple of factors. First and foremost, you have to belong to a Native American federally recognized tribe or be able to verify tribal descendancy through either enrollment number, census data, and then you also have to have connection to that community through their tribal program. So if you are serviced by Indian Health Service, that would be a direct service hospital, or if you are serviced through what we call a Title I 638 contract tribal healthcare center, that would be your healthcare center located in your tribal community, be that in South Dakota, North Dakota, any of the states.
If people had further questions on that, our eligibility, they can contact you. Are there local clinic?
I would recommend contacting your local tribal health center or community or Indian Health Service facility so that you can get the most up-to-date eligibility requirements, specifically when it comes to tribal enrollment, because every tribal nation has different enrollments, expectations, and eligibility requirements. So we want to make sure that if you're going local, that you know the tribe's requirements for enrollment to be part of the federally recognized tribe.
Thank you for that.
Mm-hmm.
Can non-natives access care?
Non-natives, if there's an emergency situation and there is a IHS direct service facility located close in proximity and they need services under federal law, EMTALA, we do have to provide them services. So non-natives in an emergency urgent situation where they need care, they can walk into a Indian Health Service ED and we have to provide them care regardless of payment.
Thank you so much.
Mm-hmm.
Now I'm going to move on to Dr. Glenna Stumbling Bear Riddle. And the reason we're doing these different systems is because they kind of stagger and work off of each other and referrals happen and things like this. So this is why we're doing this way. Glenna, can you talk about some of the benefits of private practice?
Sure. So where to start? Because I think there's a lot of benefits. And one thing is, I mean, all these systems are wonderful, but I think there are a lot of Native people out there who don't know that they can go to private practice and that could be a good resource for them. So I always really try to advocate that. But I think one of the biggest benefits is sometimes our larger systems, like it could be the Indian Health Service, it could be a university counseling center. The system is just really overwhelmed because of the high need. And, you know, one of the awesome things, if there has to be an awesome thing, I guess the silver lining with the pandemic is that it really did get people to start accessing care, to be more comfortable with therapy. However, what that means is, you know, there's really not enough behavioral health providers to meet the demand. So in private practice, one nice thing about it is that let's say, you know, maybe the person goes to college and they have access to the college counseling center, but that college counseling center may not be able to get them in, you know, on a weekly basis or even a bi-weekly basis. They may have to schedule appointments, you know, months out. And especially if somebody is dealing with suicidal ideation, you know, it's very necessary that they get into care much more frequently. And so I think that's one of the nice things about private practice is usually the psychologist or therapist has a lot more freedom and flexibility in terms of scheduling and helping the client, you know, with their treatment needs. It can also be, you know, very accessible. So in some of the other larger systems, I mean, people are still using telehealth, but some places are moving away from telehealth and wanting in person, but there's still a lot of clients that prefer telehealth work just because they don't have to worry about how they're going to get there or taking off from work. They can just kind of easily add it into their life. And so I think that definitely helps. Depending on who you see, it may also increase access to indigenous providers who may also use traditional healing practices. And so for, Native clients, that's really important. Sometimes in these systems, there's different policies and procedures, that it can be difficult to get around some of those things. But in a private practice setting, basically it's the person that owns the practice that can kind of decide what their policies and practices are. So there's just a lot more flexibility. Sometimes we hear people are concerned about privacy, like maybe their aunties and cousins and, grandparents all work at the clinic, which is a beautiful, wonderful thing, but they could have some, anxiety about, well, what if my auntie sees me going in there and I didn't really want her to know? So again, private practice can be a really nice solution because, likely your family probably, may or may not work at that practice. So, you can have more privacy there. So those are just a few, but I am definitely a big fan of private practice.
Thank you for that perspective. How do tribal referrals within tribal health services work?
Okay, so it basically comes down to setting up as a vendor. So it's like I have right now, I have a few tribes that I work with, and so that just takes me collaborating with the tribe, and then I get set up as a vendor. And then usually what happens is, I guess what most frequently happens is, at least in this, it could happen either way, but sometimes if a client, maybe they're going to their local tribal health system, but maybe it's more convenient for them because of where they live to go to the private practice, or maybe they're needing a specific treatment that's not available at that local clinic, and that's why they really need to go to the private practice. So a lot of times the tribe, they can set me up as a vendor, so we contract together, and I'll either, be like secondary. So if they have some insurance, then, their private insurance is billed, and then the tribe may pick up whatever the copay is. Or for individuals that do not have insurance, then the tribe is primary. And so it is a little bit of a process. Like, you basically bill the tribe, and it's a little bit different of a system than it is with just like private insurance, but it still works. And so it's just a matter of building those relationships, making sure that the tribe gets to know you, and that, you have a commitment to seeing their members, and you just set up as a vendor, and then they send your referrals and you start to do the good work.
Thank you for that. It just sounds like it's really communicating and knowing your tribal services policy and the private practices policy as well. What would a non-native person in the system need to know?
I think the biggest thing, I kind of started with this, is that, Native people can also benefit from private practice, and that there may be a way to kind of assist in that and to not overlook that, because I think sometimes it's kind of it's forgotten about. And it's a really great resource, especially if someone, like I said, is, having a lot of suicidal ideations, just for them to get consistent care. So I think that's the biggest thing that would be important for a non-native person to know, because I mean, it could be possible that that person's tribe, or, if they're using IHS and they go through purchase and referred care, that they potentially still could have access to private practice. So I would just say, don't, even if the person doesn't have insurance, don't rule that out as not an option for that person. So I guess that would be the biggest. And then just, making contacts. I think it's really important. Because especially if you've never worked in that system or you're not really familiar, I think the more people that you get to know, because you don't have to have all the answers, but you got to find the people that do have the answers and can kind of help you navigate that system, for that client or person in need.
Thank you.
You're welcome.
I saw a question come in the chat. Do we have time to get that now? So the question was, and I think it might be timely for it, is there a way to find out what private practice partner with IHS? And that might be a question for either Pamela or Glenna.
I am not aware of a resource like that, but I think that is a great idea.
Or is that something that we just, is that just something that Glenna, that you are Pam, that you would just communication and just find out? And is it, if it's, so say you wanted to go to you, Glenna, and you weren't part of the, a vendor, is it something that, hey, I would like to go to you and you're not a vendor and do the paperwork and all that?
Yeah, and that happens a lot. Somebody, they might want to see me. I may not be set up yet. So it's just a matter of, coordinating with their tribe to see if that's something that they'll do. And also if they have the funds for that, because, sometimes the funds are just not there. But I don't know of a resource that would say, yes, this person is, you can see this person. I think a lot of that's probably internal. But yeah, I mean, you just get set up if it doesn't exist, if the tribal clinic's willing to do that.
Okay, thank you so much.
It would
And
really
then we can
depend.
move on to Dr. Oh, did you have something to say, Dr. Endhorn?
Yeah, it would really depend upon what you mean by partner. If
Okay.
you're looking for a specialized service that your area, your specific tribal community, either in-house service, direct service, or your 638 has a partnership with, and you want to access that, the local would know that generally. If it's a specialty service where neither the 638 or IHS have access to those services, and you're looking to go through something called purchase and referred care, which is a fund that in-house service, direct service tribes actually have, so we can send you out for specialized services, specifically for behavioral health. It really will depend on if you meet the eligibility requirements for purchase referred care, which is still the eligibility to receive care within IHS. But then in addition to that, there is a residency portion that you would have to meet in order to be eligible for the purchase referred care. And then it really would come down to whether or not the facility has the funds to refer you for that specialized services. Purchase referred care specifically is what we call the pair of last resort. So if you have a situation where you need a specialized service, think psychiatric emergency services, individuals who have to be placed in a facility or require a higher level of care, purchase and referred care is usually that avenue in which is utilized to fund the placement. Sometimes they have access, or they may have availability to access different types of services. So you can make that request through your primary care doc or through a physician within an in-house service to request that services. And it would really be up to the facility at that time, whether or not they have the funds to actually get you a referral to there and for you to obtain the service.
Thank you for that information.
I could add something really quickly. So we are a private practice as well. And what we have worked out with IHS is they have, one of the tribes we partner with has grants through IHS for behavioral health services. And so when an individual comes in to receive services, they just refer them to us, to the private practice, and we're able to serve any age that is within that service delivery area for that tribe. So I think it's really going to be tribally specific or area specific.
Thank you for that information. Again, it's knowing your area and communicating with your local tribe and local IHS region.
And then the other
Absolutely.
point, make sure on both ends that as the patient, you're signing a release of information so the two providers could share information between the systems, because that sometimes doesn't happen. So you want to make sure it happens by signing a release of information.
make sure all your I's are dotted and T's are crossed, and even your J's are dotted, huh? Nobody dots their J's. Okay, I'm going to move on to Dr. Warrior. Please talk about the tribal services that your organization provides currently and the chat line you previously ran.
Yeah, absolutely. So our clinic is really unique, and anytime I give a presentation, it's really important for me to provide practical steps and almost like a call to action. So basically what we're sharing is things that we hope that you'll be able to take to either enhance services or think about things a little bit differently in terms of what service delivery looks like. So for our organization, as I had mentioned in our introduction, we started with the Winnebago Public School on that reservation. And that was just through a contract. And so for our clinic, we have to have multiple streams of income in order for us to operate functionally and in a culturally responsive manner. And the reason that is because we have a high number of relatives that do not have insurance. And so that comes into play when we're talking about service delivery. And then the other piece is that our services are not just about, we're going to be in our office, you're going to come and see us, and we're going to bill for that. We're way more than that when it comes to true behavioral health care. And sometimes that includes, if I have someone who is experiencing suicidal ideation, they're endorsing that, they have a plan, that may call for an emergency sweat. That's not something that's billable. But because we have these multiple streams of income, we have these relationships built with our partners that we're able to make that happen during our clinical day. The other piece that we do is, we provide meals for our relatives. We, especially during times of trauma. So if we have a number of deaths in the community, we're able to support those families. We're able to give items, whether it be blankets, baskets, foods. That's all part of the clinical service that we provide. So it's, again, not just being in the office. It's really about being integrated into the community. So with that being said, we're pretty much everywhere. We are located in the tribal colleges that are here in Nebraska. We're co-located in each of the schools that are located on each of the reservations. We have our community clinics that are just kind of open. And to kind of go back to what Dr. Stumbling Bear had mentioned in terms of the anonymity, with our community clinics, we also do like parenting classes, we do ribbon skirt making, we do regalia making, drum making. So people may be here, but you don't know if they're here for sessions or to have lunch with us, or they're doing a cultural activity. So there is that anonymity that is built into the clinic. So it just feels like it's a safe place in the community to be. And then we also do integrated care. And that's been really helpful for us in terms of how we're working with our relatives and them having even better attendance with their medical appointments as well. So it's really a wide range of how services are delivered, but that all started with partnerships. And when I say partnerships, that could range from like cleaning at events, showing up and helping put things together, doing presentations, volunteering for many different things throughout the community. But it starts with building those relationships, as Dr. Stumbling Bear had mentioned already. That's huge for us. And that follow through and that commitment has been really important. So we've been doing this since 2012. And I think our team has really changed the landscape of what behavioral health service delivery looks like. And now at this time, a lot of our services, that I would say like 90% of our services are driven by community requests. But I think that's huge because that's how integrated mental health awareness is in our communities now. It's a regular thing to be called in by the Human Services Department and give presentations or work with the team. So it's very broad in terms of what the work looks like with the tribes that we serve, because it's based on what they're requesting. We have our specialty area in terms of when we create our treatment plans, what those look like, the evidence-based practice that we do, and that being standardized to an extent for us, but then also really driven by community needs, community communication as well.
Thank you so much. That sounds so beautiful. I want to go there.
Come eat with us.
Eat or make a skirt or do
Right.
something. Yeah. How are your how are or was your staff trained?
Yeah, so all of our staff are required to go through the TFCBT training that was adapted for American Indians. We've also done the parent-child interaction therapy that's also been adapted to our population. But then we have our own in-house training. So there's two sets, because what I didn't talk a lot about with all that I've been saying is the chat line. And so with the chat line, we had worked with the Kansas Suicide Prevention Headquarters, and it was a series of training basically that took months for our agents to be able to qualify to work with our group. But we were very integrated, and they did, headquarters did a phenomenal job in allowing us to kind of adapt what their training looked like to how it would apply to our reservations. And so when we had case examples that we would have to go through, we would be able to change those to fit to something that we would see in our tribal communities. And that was huge. And they allowed their entire team to work through those as well. So it was a really nice coordination there that happened with headquarters out of Lawrence, Kansas. For our clinical team, in addition to making sure they have those trainings, we actually have, and I know that this is not going to be, feasible for a lot of places, but we have essentially like a 30-day orientation. And what that includes is getting to know our communities. So one, you are going to do volunteer work in our communities. You're going to spend time touring the communities. You're going to get to know different partners within the organizations. But then there's also going to be some of that didactic training where we're going to talk about ICWA and the impacts that has had in our communities and what we're currently experiencing. We're going to go through training on historical trauma. We're going to do some case examples. And so before you can serve anyone from our tribal communities, you have to know who we are. And that's also on us. If we're going to bring you here, we're going to commit to you as much as we expect you to commit to our communities. So our training is very extensive. And that was just kind of a drop in the bucket on it. Might feel overwhelming to our team members, but it's really important to us that you know who you're serving before you try to go out and provide this clinical practice. That's so vital that you know the community and that they know you as well.
That's beautiful. Thank you so much.
Mm-hmm.
Can you talk about how you were funded?
Yeah, so, I had mentioned we have the multiple streams of income. So we do contracts with schools, we do contracts with the tribes, the IHS contract is one, and then we have our private billing that we do as well. We do consultation for various things. Some of the presentations that we provide are paid. But whenever we can partner with tribes to write grants for, let's say, through SAMHSA, that's really been huge for us. And that's a way that we were able to fund our chat line. And with our chat line, we were very intentional when it came to how we hired people, who we hired. And so we had people of all ages from all of our tribal communities. We had male and female, and then we also had cultural leaders that were part of the chat line. And so had to make sure that we had enough funding to cover those positions for that time frame. So again, it comes from multiple streams of income, but the partnerships with the tribes is what is huge.
Thank you for that. Yeah, funding, coming along funding is not always easy, but thank you for looking at those different ways and making it work for your community and where you're at. Thank you for that. So now I'm going to move along, and these questions are going to be for any panelist. And we have kind of come together as a group to discuss these and came up with these questions together. And this is for the attendees as well, to for you to put in the chat for some questions you may have as well. So how do the systems interact with each other and other systems? For any panelist. I know that's a loaded question.
I can go ahead and start because we're because of how integrated we are. And I think it was a little bit different for us. But you know, earlier you had asked about the benefits of private practice. Something that's really beneficial as well is that for us, it really doesn't matter who's running the system, because we're here, we're able to operate independently, and we can continue to make those connections. And that's been huge for us. Now, with the systems that we work with across reservations, there are multiple, I guess, task forces, you could say. So, you know, with one of the tribes that we serve, we have a suicide prevention coalition, and that's like multiple schools from different counties. But as long as we have a student from that tribe that goes to that school, they're part of that coalition. So and there's a lot of like environmental scans, basically, you could say, to where we're keeping track of who is who, where they are, and then how can we partner with those organizations. And so there might not always be that exchange of funding, but there's a lot of MOUs that are in place to make sure that we can have that communication. I think with the growth, especially due to the pandemic, we've had much more buy-in in terms of services. So each of the schools in these counties in our areas, they have release forms, they have referral forms. And so it's just a quick fax. And then we have enough outreach team members that can coordinate services across agencies. So I think, you know, with all of the hardships that were brought on by the pandemic, it also brought systems together more to work collaboratively. There's more communication that's happening, and there is more sharing, and that comes from that documentation piece. So like, you can go to the school and get these documents to go to Indian Health Service, or to Morningstar Counseling, to our clinic, or to anywhere else programs, but those forms are there. Their social workers are on it. So that's been huge, something that I've seen, especially since the pandemic.
Thank you for that, Dr. Warrior. Dr. Endofhorn, Dr. Stumbling Bear Riddle, anything to add?
For Indian Health Services, it really depends on the area. It depends on the area, depends on the facility. And that's kind of like my answer to a lot of things. It's like, really? Yes. Simply because when you think about all 574 federally recognized tribes, we're all unique. And every single one of us has different resources, culture, language. And so when you really have to think about what kind of treatment you want, what kind of services you're looking at, it really comes down to the local level. And we really want to, as Indian Health Service, acknowledge that and respect that every tribe is unique. And so one of the best ways to do it is to make contact with your local facility, your local 638 program, if there is one, or your local self-governance, especially thinking about Alaska. Contact them and see what it is that is available, what's not available. And I love the point that was made by Shannon Dial in the chat, is that that's the most important piece, because certain things are covered and certain things are not. And we have a lot of really good partnerships with, like, Department of Veterans Affairs, with Department of Interior, with the Bureau of Indian Education, Bureau of Indian Affairs. But it really comes down to that local level. What is it that they set up for themselves? How are they meeting the local need? And what is being funded? What's not being funded? What's a gap in service? All of these pieces really have to be at the local level because of our uniqueness.
Thank you. Thank you. Anything to add, Glenna?
No, I think that was covered pretty well. So I can't really think of
Yes.
anything else.
This is a huge one. What are the barriers?
Transportation. Transportation is one of the biggest barriers in Indian country, simply because when you're looking at it, 70% of our population lives in urban, which is fine. And they can access services in an urban area. We have urban Indian health organizations. You can use private insurance, Medicaid, Medicare. It's when you get into the rural tribal communities, in the geographically isolated areas, transportation becomes one of the biggest issues. That leads to all the other barriers: accessing appropriate services, being able to recruit and retain qualified providers to reach out into those rural areas. And then looking at it from the perspective of certain services don't exist in our area simply because we cannot recruit and retain those specialized providers. And so when we're thinking about it, our population tends to also be highly mobile. I go home a lot. People go home and receive services at home versus receiving services in the urban area, which is their right to do. But it's going home to be comfortable, being served by people that you know in a way that makes sense to you and is really respectful and aware of your cultural heritage. This plays a role as well. So transportation becomes a barrier, distance becomes a barrier, and then definitely accessing the services is what the end result becomes.
Yeah, along those lines, I would just add, inflation has just really been just awful to deal with. And so kind of going back to that too, like a lot of times maybe people have the car, but they don't have the gas money to actually get to all these appointments, or they're having to, drive great distances, or, maybe there's not a local psychiatrist, but there's already, not enough psychiatrists anyways, but then depending on where you're at, the nearest one may be hours away. And so it's just like there's multiple layers that just kind of stack up on each other. And, like I said, the need is really high, yet there's really not enough providers to meet that need. I think that's why it's so important that we're doing more of this community work, because, there's the need is so great, and there's not enough behavioral health providers. And so that's where the community can kind of step in and assist as well. So I think that's a big barrier too, is just kind of going off of transportation, is just costs of everything right now.
Yeah, I would add, several years ago, HRSA had conducted a study, and they were looking at some of these barriers. And these are things that are still a challenge for us today. And this is going to be more so with our rural communities and our reservations, but it's accessibility, acceptability, and availability. Those three things impact us like no other. And, I think with the pandemic, acceptability is starting to happen because there's so much awareness now about mental health, and the online sources that are available. But the accessibility piece there is going to be the challenge too. So when we're talking about how can we get to those services, and what does our Wi-Fi networks look like? How consistent are they? Because I know when we were doing services through the pandemic, specifically for our reservations, when we couldn't do in person, telehealth was so inconsistent. It was a major, major challenge for us. So we were having to do a lot by phone, and then the availability of our providers. So for our clinics, we do a lot with children. That's mostly who we work with. But when you're the only practice that's providing services for children all across the state, it's going to be easy to be overbooked, or to have an extensive wait list. And so that can sometimes be a barrier for us as well. And as Glenna mentioned with the psychiatrists, medication is always our last resort, but sometimes that does have to be the option. And then we're looking at 3 months out at a minimum before we can get someone seen for that. So those are some of the major ones that I think are always important for us to recognize, is that accessibility, acceptability, and availability of providers and services.
I like that, the AAA, and not the AAA that we know for our cars, right? What are some unique features for attendees on the webinar to know?
I think within an Indian health service, when we think about IHS, we often think about that it's just one system. And the reality is it's really tribal programs, which is 638. It could be federal, and it could be self-governance. So it can be a myriad of different services being offered differently across tribes. And often people think, well, you know, I went to one IHS, I know what IHS is about. Just like VA, I often say, if you've been to one IHS, you've been to one IHS, because everybody's different depending upon how that tribe has structured their services, where they're located geographically, and what kind of services they even have access to. And so it really comes down to what is the tribe like? What are they focusing on? What are they pushing for their people? And the piece that often gets lost in that discussion is, you know, what is it that they are doing to solve their problems that they are aware of? And often, you know, people bring up, well, suicide, alcoholism, substance abuse, and that is true. But we also do have communities within Indian countries that don't have a suicide problem. They actually have zero suicide. Whereas we do have some communities that have very high rates of suicide. So when you see one tribe, you see one tribe, and every tribe is different. And I keep saying that, but I really want to make sure that people are aware that every tribe has their own unique needs, their own unique barriers. And it really is a disservice to try to compare and contrast different tribes to each other.
Thank you for that. Just like there on this screen, there's 4 Indian women on here, but we're very unique for Indian women.
Absolutely. I appreciate what Dr. Endifhorn said, and just to echo just another step is one of my biggest frustrations is when someone's coming to me for like questions on resources. Maybe they're seeing a Native person, and so the first question I always ask is, okay, well, what's their tribe or nation? And oftentimes I'll get hit with, well, I don't know. I just know that they're Native. And it's like, we need more information. And so I would say, you know, a big takeaway is just make sure that with the people that you're trying to serve, even if you know that they're Native, that's really not enough. You need to know more, so then you can help them connect with those resources, because like what's been shared, it really varies depending on, you know, what tribe, where you are geographically. And so you've got to ask that question. Please ask that question.
Thank you for that. Yes.
I think the piece that I would add in terms of the takeaway would be, again, going back to the private practice, the partnerships, and the relationships. That's huge, because what you're doing when you're looking at these various options is you're empowering that relative as well. And that's using a trauma-informed approach, because they're now going to have choice. You know, so when we go through trauma, that's not a choice for us to do that. That option is taken away from us. But when we do the legwork as clinicians, and we see that we can build these relationships, we can establish partnerships, so there are options, and our relatives are empowered to make the choice on who they want to serve them. That's where we start. That's where we go. That's how we make a difference. So that would be something that I hope that all of our participants are able to take from our conversation today, is the power of those relationships, and even thinking outside the box in terms of how we can make those relationships happen, because there are many ways, and we don't have to stay in, well, this is how it's always been done. Great, now let's look at how else we can do it. So, and I think for me, as someone who is like always pushing the boundaries, that it's something that has been a little bit easier for me to do. But that it's been major, and it's made a difference in the number of people that we've been able to provide quality services to across the state of Nebraska. Thank you.
Thank you so much to the panelists. This was just a great wealth of information. And like I said at the beginning, we could spend a couple of days on just the Indian Health Service structure, how it came about, the history and all that. And then maybe another day on just the tribal health services, and then private practice, and then just insurance itself. One thing that I want everybody to remember is Indian Health Service is not insurance. It's services. It's not insurance. And there are some tribes that have their own health insurance, and some tribal members, descendants, all that may opt and have their own insurance. I, for one, have my own health insurance from where I work. So, just don't assume that everybody wants to go to a Indian Health Service facility, clinic, things like that. People have options and all that. So I want to, again, thank my panelists, and I just enjoy working with all of you. I look forward to when I can interact with all of you. I feel honored just to be in your presence and all that, and just learn so much from all of you all the time. I want to just put the opportunity for the attendees to put questions in the chat. I know there's been a couple of questions about cultural competency trainings. So we did do a webinar on cultural humility, and that should be out there. You can contact us on doing some trainings on cultural humility. I don't accept competency because I'm not even competent in my own tribe stories and everything on that. So how can I be competent on the other 570 whatever things like that? So I don't accept competence because I'm not even competent in my own tribal stuff. So that's why I call it humility. But we can do the best that we can and get trainings on that. And I'm sure all my other panelists will help you the best that they can. And then I also wanted to let you know, Angie is the lead on developing a resource guide, and it's going to probably take, a year and a half to get that out. And it's going to be an interactive guide, and she's going to be able to let you know what private practice and Indian Health Services facility, tribal clinic, any clinics, what insurance they accept, who do they accept? Do they accept just tribal people? Do they accept non-natives? Just things like that. And it's going to be an interactive guide for everybody. And then Scott Barton is his second week in. He's the assistant director of tribal initiatives at SPRC, and he's working on a fabulous training, and it's going to be a regional training. Plus, before you get to the regional part of it, there's going to be two modules that you have to take, and it's going to be on trauma-informed care, our historical trauma, and then the urban Indians module you have to take. But it's going to just do some of this trainings that we've been talking about, our people have been putting in the chat. So some things that SPRC is working on are the tribal initiatives team. So if you all have some ideas, attendees that, are some resources or trainings or needs that you have, just let us know. Angie or myself or Colleen or anybody at SPRC, just, put those in there and maybe we can work it up. So we have two other webinars coming up. Let's see, the next one is on tribal sovereignty, and that's in July. And then the final one is jurisdictional concerns. But again, I appreciate, and as some of the panelists were talking, the amazing Angie was putting links in the chat. So just check out the chat and make sure you got captured some of those links. I appreciate your time. And again, I appreciate the amazing panelists that we had. Thank you so much.
Thank you.
Thank you.
I didn't know if there were any other questions.
Thank you.